Welcome to Endodontics Part 1. The slide presentation is targeted to the dental assisting student. Let's look at the definition of endodontics. So the definition is a dental specialty dealing with the diagnosis and treatment of disease of the pulp and periradicular tissues. So at this time, a lot of this terminology should be very familiar to you. What might be new is the term periradicular tissues. So peri meaning around, radicular would be around the apex, and though that tissue is alveolar bone. The indications for endodontics could be a periapical abscess, decay involving the pulp, a fracture involving the pulp, necrotic pulp caused maybe by trauma, or necrotic pulp can be caused by a fracture or decay or an abscess. Root resorption and hyperplastic pulp, which can also be caused by decay or a fracture. Contraindications would be a conservative approach, which many general dentists do practice, where you'd have a near exposure of the pulp or minimal exposure of the pulp. Let's look first at the indications. So thank you to the internet and other sources for photos. This is a periapical abscess, very evident on a periapical radiographic image. You can see that the tooth has been fractured into the pulp chamber and into the canal. Therefore, that trauma has caused a periapical abscess for that tooth. Then we have some photos showing decay involving the pulp. Very gross decay. Remember, gross doesn't mean ooh yuck. It means a lot. So definitely a lot of decay here. From a radiograph, you can see how much tooth structure has been lost to decay. Now, this tooth already is showing evidence of endodontic treatment, but the focus would be the loss of tooth structure and into the pulp chamber from decay. Then we have rather large class 5 decays here in the anterior teeth. Fractures involving the pulp. So here's some teeth that have been fractured, probably due to an accident, to trauma. Here's another fracture in a posterior tooth that may indicate endodontic treatment. Now, necrotic pulp, often by trauma to the teeth. Sometimes, though, you see that there are no fractures that can be seen clinically, and the mere blunt trauma to the tooth has caused a pulp to become necrotic, and therefore the tooth is discolored. So sometimes if you see a discolored tooth in the dentition, that can be a sign of a necrotic pulp. Root resorption, where in a radiographic image you would have blunt root tips. Sometimes this is caused by trauma. It could be caused by orthodontic treatment in which the teeth were moved too fast, didn't have time for that tension, which cues the osteoblasts, and in this case the cementum and dentin to develop or re-establish itself. A hyperplastic pulp, often caused by gross decay or a severe fracture, where the pulp actually becomes inflamed and exudes from the pulp chamber area and from the canals. The conservative approach of pulp capping is when there is a near exposure or a minimally exposed pulp through the pulp chamber. So when a dentist or an endodontist, a lot of times the GP, removing decay, and the dentin at the floor of the pulp chamber has a pink hue to it, that would be considered a near exposed or near exposure of the pulp. And a minimally exposed may be just an area where there's a little seepage of blood in the pulp chamber. Well, many dentists feel like they want to give this tooth a chance to perhaps heal, possibility of the pulp to heal, so they place a resin-modified glass ionomer as a liner to seal that, and that may give the pulp a chance to heal, reverse, so to speak, some dentin to form, and reparative dentin to form, and therefore a endodontic treatment is avoided. And so perhaps in this situation, the dentist may place some type of a temporary restoration to give the tooth time to heal. And that is the pulp capping, which is a conservative approach. Other pulpal conditions that could occur would be pulpitis, inflammation of the pulp, hyperemia, where there's increased blood flow, hypersensitivity, where the patient just in the slightest tapping or slightest stimuli feels some sensation, or way to the opposite side, with some stimulation, they feel nothing, a necrotic pulp. Now, this doesn't always warrant endodontic treatment except for the necrotic pulp. But with a chronic pulpitis, that may warrant endodontic treatment. You don't actually see an inflamed pulp, you don't see hyperemia, but that is the part of the diagnosis when people have toothaches or hypersensitivity. Or clinically, we've already looked at a picture of what a tooth looks like when there is a necrotic pulp. Symptoms, subjective and objective. So this is a bit of review. So subjective symptoms are, yes, that's right, what the patient feels. So a patient can report that they have pain, or for some patient with a very high pain tolerance, it may just be a sensitivity. Objective symptoms are, yes, that's correct, what the clinician sees, what the dentist, what the endodontist sees. Now, there are some objective symptoms such as mobility, inflammation, even a fistula, brexing, clenching, oral habits that a patient actually feels and will report. People know if they have, most of the time, they know if their tooth is suddenly mobile. They said, my tooth feels kind of loose. Or something to note, sometimes people say that their tooth feels high, like when they bite down. Well, that is usually a sign of that inflammation of that abscess, where a tooth actually extrudes from the socket area. Or there could be decay that may be detected only by the clinician. Inflammation at the gingiva and periradicular area. The patient may actually have some experience and report on that. A fistula, we're going to look at that in a moment. A fistula is a canal by way or by which infection can make its way to the surface of the tissue. Looks like a blemish or, quite frankly, a pimple. We'll look at that in a moment. Or the patient could report brexing, clenching, or oral habits. So let's look at that fistula, which would be new to you. So sometimes a patient might say, you know, I had kind of a pimple on my gum and then it went away, but my tooth is still hurting. So this was the attempt of the body to get rid of that infection. So purulent matter or purulence, pus, could come out of this fistula and this blemish. These are, so that you can see, these are actually periodontal fistulas, where you could actually put an instrument and follow the path, or put a soft material called gutta percha, follow right into the blemish, and you can follow the source. And again, this is a periodontal abscess, not a apical abscess. The diagnosis for endodontic treatment would begin with a clinical examination, diagnostic quality radiographic images, and could involve a series of vitality tests. So we're going to look at these vitality tests now. The first two are percussion and palpation. So percussion, the dentist usually takes a mouth mirror handle and taps on the tooth. Sometimes they do this even when the patient says, "This tooth aches." It's kind of like just an automatic response. But really it would be if a patient would say, "I have a toothache, I'm not sure which tooth it is up here or down here." So the doctor may tap the tooth, which is percussion, with the mouth mirror handle to see if one responds more than another. Or palpation, where they actually press on the gingiva to see if there's any pain reported by the patient. Sometimes you could have some purulence or exudate from the tissues. Electronic pulp testing and thermal testing. So electronic pulp testing uses a pulp tester that provides a stimulus to the patient's tooth. We're actually going to shock the patient's tooth, but we don't say that. We say we're going to stimulate the pulp. So when you feel a tingling sensation, just raise your hand. So you drive the tooth, you put a conductor such as toothpaste onto the tip, which goes in the end. You press a button and it has a stimulus, and then you could increase the stimulus. Certainly if a patient doesn't feel the stimulus at all, that's usually a sure tell sign that the pulp is necrotic. Thermal testing is usually with cold. There is endo ice, which is like dry ice, but in a kind of a gas form in a spray. And so that can be sprayed on a cotton pellet or a cotton tip applicator. Certainly, just like these photos, the teeth need to be isolated, and then to see if the tooth responds to cold. Or you could simply use a piece of ice. So if you are one of my students and in California, you want to review the scope of practice for the DA, the RDA, and the RDA-EF when it comes to vitality test and exposing radiographic images. Mobility would be when the dentist uses a finger usually and a mouth mirror handle to see how loose the teeth might be. Again, they can become loose with an abscess. Selective anesthesia. Once in a while when a patient just isn't really reacting definitively to some of the other vitality tests, the doctor could actually anesthetize a quadrant and see which tooth is not getting anesthetized. When a patient has an abscess or severe infection, it's usually difficult for the doctors to anesthetize that tooth because of the pH difference. So you have an alkaline anesthetic solution and a acidic infection, and so those two just don't mix, and sometimes anesthesia does not affect a abscess or necrotic pulp. It's probably not a very common vitality test to use. Transillumination. It's a very bright light that can be used to see fractures, maybe how deep the fracture can be. It really only is for the crown of the tooth, and doesn't quite, because the root is embedded in bone. Lastly, it would be removal of decay. Not quite like this, just wanted to add a little humor. And so this is from Little Shop of Horrors, which was a play and a movie. And so removal of decay, sometimes the dentist will remove decay with a radiographic image. Sometimes it's not always definitive as to how deep the decay is. And so by removing decay, they can see, is there a pulpal exposure? Is there a near pulpal exposure or a minimally exposed pulp? And then determine the treatment. So I thank you very much for listening, and stay tuned for Endo Part 2.